Patients at Somerset Medical Center were dying quietly, too quietly. They were elderly, yes, sick, often, but something felt off-kilter in a way that nurses couldn't explain and doctors couldn't quantify. Their vitals would crash without warning. Lab results stopped making sense, and always nearby, calm and quiet, was the nurse. Charles Cullen, kind eyes, steady hands, the kind of man you'd trust to sit beside your loved one in their final hours. He smiled, spoke gently, and offered comfort. But behind that sterile professionalism was something far darker. For over a decade, Cullen moved silently from hospital to hospital, cloaked in the chaos of the American healthcare system. He didn't kill in the shadows. He killed under fluorescent lights, with syringes and saline bags, hidden in plain sight. And by the time anyone truly noticed, the damage had already been done. He may have murdered hundreds. Long before he was a nurse, Charles Edmund Cullen was a boy shaped by absence. Born on February 22, 1960, in West Orange, New Jersey, he was the youngest of 8 children. His father, a bus driver, died when Charles was just 7 months old. His mother, to whom he was especially close, was killed in a car accident when he was 17. That final loss fractured something in him. He dropped out of high school shortly after. Cullen enlisted in the U.S. Navy in 1978, seeking stability. Instead, the isolation and pressure seemed to deepen his unraveling. He began exhibiting bizarre behavior, once donning a surgical mask and gloves while manning missile controls, another time found curled up in a fetal position in a torpedo room. After several suicide attempts, he was discharged in 1984. The official reason was medical. Unofficially, it was clear he was mentally unwell. That same year, he enrolled in nursing school. By 1987, he was a licensed nurse, employed at St. Barnabas Medical Center in Livingston, New Jersey. It didn't take long for strange events to begin. Patients who had been stable would die unexpectedly. Medications would go missing. Colleagues suspected something, but Cullen was always just out of reach, soft-spoken, helpful, seemingly competent. Over the next 16 years, Cullen bounced from hospital to hospital, always under a shadow. Whenever suspicions grew, he resigned before he could be fired. Red flags followed him, but the healthcare system failed to connect the pattern. At times, he was even given neutral or positive references. His personal life showed similar cracks. His wife filed for divorce in 1993, alleging bizarre behavior, burning family belongings, abusing pets, and spiking drinks. Still, he kept getting hired. Each new hospital brought new victims, and no one, not administrators, not co-workers, not even the families of the dead, understood that they were witnessing one of the most prolific serial killers in American history. The pattern was simple, almost surgical. Cullen would target patients who were vulnerable, elderly, recovering, or simply inconvenient to hospital staff. He began using digoxin, a powerful heart medication, to induce sudden cardiac arrest. In other cases, he used insulin or epinephrine, quietly injecting lethal doses into IV bags or directly into patients. These substances wouldn't immediately raise alarms. Many victims were already ill, making their sudden deaths easier to write off. Cullen counted on this ambiguity. It became his cover. His first known murders occurred at St. Barnabas Medical Center in 1988. Several patients died unexpectedly during his shifts. When an internal investigation uncovered a suspicious spike in digoxin levels in autopsied bodies, Cullen resigned. There was no criminal charge, no formal accusation, just a quiet exit. From there, he moved to Warren Hospital in Phillipsburg, where the pattern resumed. In 1993, an elderly woman reported that a sneaky male nurse had come into her room late at night and injected her with something. She died hours later. Her family pushed for answers. The hospital performed a toxicology screen, revealing lethal levels of digoxin, but decided not to report it to the police. Once again, Cullen left before consequences could catch up. He found new work easily. His resume was clean. References stayed vague. Healthcare administrators feared lawsuits more than they feared suspicion, and that silence gave Cullen room to keep going. At Hunterdon Medical Center, he worked in critical care, where medication access was wide open and oversight was minimal. When patients died, no one looked too closely. In 1997, Cullen moved to Morristown Memorial Hospital. That same year, he attempted suicide twice and was briefly committed to psychiatric care. He confessed to feelings of hopelessness, but never to what he'd done. His psychiatric history, though extensive, didn't follow him between employers. Mental health privacy laws kept his records sealed, and so each new hospital welcomed him without question. By 1999, Cullen was working at Liberty Nursing and Rehabilitation Center in Allentown, Pennsylvania. He was supposed to provide palliative care, easing the suffering of elderly residents. Instead, patients began dying at an alarming rate. Cullen was caught tampering with medication carts, but no charges were filed. He resigned yet again and moved on. Each resignation was another opportunity, another hospital, another wave of deaths. No hospital wanted the liability, and so Cullen was allowed to vanish into the next facility, nameless among the night shift nurses, free to start again. By the early 2000s, Charles Cullen had perfected his method. He rarely targeted specific individuals for personal reasons. Instead, his victims were often selected based on opportunity, patients he had easy access to, whose deaths wouldn't raise alarms. Many were elderly, some were recovering, others weren't even in critical condition. Cullen believed he was ending suffering, but many of his victims were not terminal. Some were even on the mend. His primary tools were digoxin, insulin, and epinephrine. These drugs, in the right doses, could save a life. In Cullen's hands, they became silent killers. He would slip them into IV bags, contaminate medication drawers, or inject them directly into saline lines when no one was watching. The effects were quick, but not immediate. A patient might crash minutes or hours later, with symptoms that mimicked natural decline. To the untrained eye, it looked like bad luck. But when viewed in sequence, the pattern was impossible to ignore. Cullen grew increasingly bold during his time at Lehigh Valley Hospital in St. Luke's. He began targeting multiple patients in a single week. In one case, he admitted to entering a patient's room and injecting their IV line while they were unconscious. In another, he added digoxin to a medication bag intended for an entirely different person. Even staff he worked with were unknowingly administering his poison doses. The death toll climbed. Behind closed doors, hospital administrators whispered. Quiet internal investigations were launched, but they rarely led anywhere. Cullen had become skilled at resigning just before questions turned into consequences. He even started altering medical records, erasing logs, tampering with dosages, deleting signs of his presence. He was methodical, cold, careful. In 2002, Cullen secured a job at Somerset Medical Center. It would be his last. Within months of his arrival, the hospital began seeing a sudden rise in code blues, emergency responses to patients in cardiac arrest. Nurses noticed Cullen often appeared nearby during these events, even when he wasn't assigned to the patient. Lab results showed spikes in digoxin and insulin levels in multiple victims. Still, there was no proof, not yet. Cullen's behavior grew increasingly erratic. He accessed patient files without cause, loitered in restricted areas, and once was found in a medication room with syringes he wasn't authorized to have. A pharmacist raised concerns. Then another nurse did. The hospital finally reached out to the New Jersey Poison Control Center. What followed would finally crack the case open, but only after at least 16 patients had died under his care at Somerset alone. By then, Charles Cullen had murdered for 16 years. Among the victims at Somerset was Reverend Florian Gall, a beloved priest recovering from a minor health complication. His condition had been improving, and he was expected to be discharged soon. But suddenly, his heart stopped. The toxicology report showed a fatal level of digoxin, one that had never been prescribed. His family pushed for answers, but they weren't alone. Gall wasn't the only patient to crash under odd circumstances. Several others, Dorothy Oltmans, Zenon Kurilas, and Ottomar Schramm, all died within months of Cullen's arrival. Some had been talking to family hours before their death. Others had shown clear signs of recovery. The deaths felt random, inexplicable, and always came back to one constant: Charles Cullen. Behind the scenes, the New Jersey Poison Control Center began compiling data. They flagged the unusual frequency of cardiac arrests and the presence of medications that hadn't been ordered by physicians. A toxicologist named Dr. Stephen Marcus became one of the key players in connecting the dots. He urged Somerset administrators to act, but the hospital hesitated, fearful of lawsuits, reputation damage, and public backlash. Eventually, they reached out to law enforcement. The Somerset County Prosecutor's Office opened a formal investigation. But Cullen wasn't yet aware. He continued showing up for work, tending to patients, moving between wards. While investigators worked quietly, the hospital brought in a nurse named Amy Loughran, a colleague and friend of Cullen's. She was asked to wear a wire. Loughran had noticed Cullen's strange behavior for months, but hadn't dared voice her suspicions. When police approached her, she agreed to help. Using her access as a fellow nurse, she reviewed medication records and patient logs, discovering alarming patterns that directly tied Cullen to multiple deaths. The wire recordings captured Cullen speaking in vague, evasive terms about helping patients die. He never admitted exact numbers or details, but the walls were closing in. On December 12, 2003, Charles Cullen was arrested at a restaurant in Somerville, New Jersey. During his initial interrogations, he remained tight-lipped, but over time, perhaps out of guilt or exhaustion, he began to talk. Slowly, methodically, he described injecting patients with lethal doses of drugs. First dozens, then scores, then hundreds. He confessed to at least 40 murders, but claimed the real number was closer to 40 per hospital, across 10 institutions. That would place the victim count somewhere between 300 and 400, though many remain unverified due to missing records, cremations, and time. The sheer scale of it was staggering, not just in lives lost, but in how long it had gone unnoticed. For 16 years, Charles Cullen had walked the halls of hospitals, undetected, unchallenged, and unrepentant. Charles Cullen's arrest sent shockwaves through the medical community. Hospitals scrambled to review old records, trying to determine how many of their own patients had died during his tenure. Families were notified, death certificates were re-examined, but the truth was buried in incomplete files, undocumented injections, and systems that had never anticipated a serial killer wearing scrubs. In 2004, Cullen pleaded guilty to the murders of 13 patients and attempted murders of 2 others in New Jersey. Later, he pleaded guilty to additional charges in Pennsylvania, bringing his known tally to 29 confirmed victims. In return for his cooperation, prosecutors agreed not to pursue the death penalty. But Cullen's admissions didn't stop with the court's charges. In interviews, he hinted that the actual number of deaths was far higher. He told investigators he couldn't even remember all the names. During his court appearances, Cullen remained mostly emotionless. He spoke in a flat, detached tone, occasionally muttering responses. When asked why he did it, his explanations were hauntingly simple. He claimed he wanted to end suffering. He insisted he believed some patients were beyond help, that he was easing their pain. But many weren't terminal. Some weren't even in serious condition, and he often made no attempt to get a second opinion. He simply decided, on his own, who would live and who would not. The families of the victims sat in courtrooms and listened to the man who had stolen their loved ones. They heard the flat confessions, the emotionless admissions, and they watched as Cullen, again and again, refused to give them closure. In one court session, when asked if he had anything to say, Cullen repeatedly muttered, "Your Honor, you need to step down," over and over. It was the only phrase he would say. He offered no apology, no explanation beyond the chilling minimalism of his earlier interviews. He was sentenced to 11 consecutive life sentences without the possibility of parole. That means he will never leave prison. His confinement is at New Jersey State Prison in Trenton, where he remains under constant observation due to his history of suicide attempts. After the sentencing, many hospitals quietly reviewed their hiring practices. Policies changed, record-keeping became stricter, and states began pushing for better tracking systems of medical professionals involved in misconduct or suspicious deaths. But the damage had already been done. Cullen had moved through 10 hospitals across 2 states, and at every step, red flags were ignored, minimized, or buried under bureaucratic fear. In the end, Cullen wasn't caught because of some grand institutional revelation. He was caught because a nurse listened to her instincts and wore a wire. The case of Charles Cullen left a scar on American healthcare, a quiet warning hidden beneath hospital gowns and sterile corridors. He wasn't the kind of killer who left blood at a crime scene or taunted the police. He left behind charts, empty beds, and grieving families. His methods were clinical. His motives, clouded in self-righteous delusion, blurred the line between mercy and murder. In the years following his conviction, journalists, documentarians, and investigators tried to piece together the full scope of Cullen's crimes. But there are no grave sites to count, no forensic trail to follow. Many of his victims were cremated before foul play was even suspected. Some were never named. Hospitals, fearing lawsuits and reputational collapse, kept silent. The true number of those who died at his hands may never be known. In 2013, the case re-entered public consciousness with the release of The Good Nurse, a non-fiction book by journalist Charles Graeber. It detailed the exhaustive investigation and highlighted the courage of Amy Loughran, the nurse who risked everything to stop him. The story was later adapted into a feature film, further cementing Cullen's name in the grim catalog of American serial killers. But the media's spotlight also reignited uncomfortable questions. How could so many institutions have failed for so long? Cullen's case triggered reforms, albeit slowly. Hospitals began developing better medication tracking systems. Some states pushed for centralized databases to flag suspicious healthcare workers across state lines. Yet critics argue that, in many places, the fundamental weaknesses Cullen exploited still exist: overworked staff, fragmented communication, and systems that prioritize image over accountability. Charles Cullen remains in prison today. He doesn't give interviews. He doesn't write letters. He exists now in the silence he once hid behind, a nameless inmate in a system he once used to kill. His story isn't one of chaos or frenzy. It's one of methodical, invisible horror. A man who walked among the living by pretending to care for the dying. He wasn't a monster in the traditional sense. He was a man in scrubs, a nurse, trusted, welcomed, overlooked. And that's what makes his story so terrifying. If your pulse burned on the edge of the abyss, consider leaving a like and subscribe to the channel. Eyes up, Seeker. The truth can't hide in the dark forever.